All right, attention, we are going to discuss chronic obstructive airway disease for the next 1 hour or so. It's a very important disease, actually. It's growing in importance in the developing world. It's much more relevant in the developed countries because of sustained and long periods of pollution. So we'll have definition and diagnostic criterion, classification of severity. We look at a bit of epidemiology. Specifically, we look at the 4 diseases. Asthma per se is not very classic as chronic obstructive, but because it's more restrictive, but you're going to do as much as possible. Chronic obstructive airway disease is a chronic state characterized by airflow limitation that is not fully reversible. It's a condition once acquired, it has a permanence, as opposed to asthma, which is reversible, because asthma is dependent on the small bronchioles that have smooth muscle, which constrict. The airflow is limited. The airflow limitation is usually both progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. So this condition, chronic obstructive airway disease per se, is a progressive disease, meaning that the patient will be deteriorating with time. And if you check the pulmonary function, every year you're going to find a pattern of deterioration, particularly if the patient has not changed lifestyle, characteristically exposure to fumes or other particles that are noxious. Prevalence and morbidity data greatly underestimate the total burden of COD. Morbidity increases with age and is greater in men than in women. We spent more time outside, we spent more time mining, we spent more time in the garage and where there's enough smoke and other toxic substances. And currently, globally, is the 4th leading cause of death. These factors are both risk factors are both environmental and host factors. The first and most important host factor is alpha-1 antitrypsin deficiency. We know this is the one that responsible for inactivating or breaking down enzymes, particular enzymes like elastase. So patients who lack this enzyme tend to have destruction of the lung parenchyma. Patients who have asthma and airway hyperresponsiveness tend to also have COD. Patients also who have disordered lung development, where there is an abnormality in the lung, then can predispose to chronic obstructive airway disease. Environmental factors: number 1, tobacco smoke. Number 2, occupational dust and chemicals. Then we have airway pollution. No, air pollution, either from the airway, the highways, or whichever way. Then I have childhood infections, whooping cough, you know, the famous fall which you do the immunizations against. Then you have lower socioeconomic status, purely because of housing and inability to have filtered environments. They tend to be in the places where the fumes are. They tend to be able to take any job, even when it endangers their lives, whether there is dust, occupational dust or chemical involved. How do we make a diagnosis? COD is considered in patients with cough, which is productive of sputum, with or without, with dyspnea or dyspnea. So patients need to have a cough which is productive and there is associated dyspnea, plus or minus the presence of risk factors like smoking, environmental or intrinsic. Then you can confirm this by spirometry, where you look at forced expiratory volume vis-a-vis vital capacity. And you can see the formulas right there. So a low peak expiratory flow has poor specificity for the diagnosis of COAD. So you calculate the formulas and you see what is below 70 and what is below 80, and it's a predictive value. The pathophysiology. Usually there is trapping of air within the alveoli. And this increases or raises the reserve volume, and forced respiratory capacity is elevated. There is hyperinflation. Due to the air trapping, there is a hyperinflation, meaning that the total lung capacity will be elevated. The other problem is that we have reduced elastic recoil pressure. Elastic recoil pressure is reduced, which means there's dynamic collapse of the airways during expiration. Remember, during expiration, the airway does not collapse. The design is that the alveoli are designed in the honeycomb pattern, which has recoil capacity. Once there is damage to the alveolar wall, there is loss of the recoil pressure and the airways tend to collapse. The patients also have ineffective cough mechanism, and they'll tend to breathe through pursed lips when breathing, and that is classic in emphysema. And these are reflex in order to increase, to prevent the lungs from collapse, the alveoli from collapsing. We also have increased compliance in eczema. And an increase in airway resistance, which we see classically in bronchitis. The patients tend to have a prolonged forced expiratory time. Specifics, let's touch on chronic bronchitis. Diagnostic criteria: persistent cough with sputum production for at least 3 months in 2 consecutive years. In 2 consecutive years or more. So persistent cough with sputum production for at least 3 months in 2 consecutive years. It can be either simple, it can be chronic asthmatic, or it can be obstructive. Most frequent in the middle-aged men. Higher incidence is in urban dwelling, may coexist with emphysema, and presents with exertional dyspnea and frequent respiratory tract infections. What is the pathogenesis of chronic bronchitis? Chronic irritation by inhaled substances. So you have chronic irritation of the airway by inhaled particles. Then we have recurrent respiratory infections. It's 4 to 10 times more common in heavy smokers, either passive or active. Then the situation is made worse by hypersecretion of mucus in the large airways. We have hypertrophy of the submucosal glands within the bronchioles, increase in goblet cells in the small airways, where usually you have few goblet cells which produce mucus, and you have excessive mucus, as we have seen, which produces airway obstruction, as we see in asthma And now the cigarette smoking will also predispose the patients to infection. What is the morphology of the disease? Gross, you see hyperemia and edema of the mucous membranes. When you open the bronchi, you see hyperemia and edema. We have also excessive secretions with or without cast formation. Cast is a solidified material. At microscopy, you see hypertrophy of the submucosal smooth muscle, 1. Hyperplasia of the submucosal glands of the trachea and bronchi, 2. Squamous metaplasia and dysplasia of the epithelium. Yes, you see change due to constant irritation. You see change from the normal columnar cells to squamous cells. You may find presence of dysplasia. There's loss of ciliary activity due to damage to and change to squamous metaplasia. And due to the hypertrophy of the submucosal smooth muscle and the increase in the submucosal glands, you have narrowing of the bronchioles. Sometimes it's complete with bronchiolitis obliterans. These are microscopic photo. Okay, this is a lining. This is a normal histology. No, this is not the normal, but this is abnormal histology. This is a lining. This is a lining columnar ciliated, under which you have prominent smooth muscle bundles, the pink fibers where we have the cursor. Then after that, you find you have these mucosal mucus glands. These glands are hypertrophied, there's an increase, and they're producing more copious amounts of mucus. And there is a diffuse inflammation, the small black dots. Chronic inflammation, you can be able to see it there. These are cartilage. These are inflamed region. These are glands, hypertrophied glands. You have edema, submucosal edema, smooth muscle hyperplasia or thickening. The glands are increasing. Yeah. So it's just a comparison of the bronchial, normal and abnormal. You see, it's basically thin walled with enough lumen. While in this other patient with COPD, emphysema, for instance, you have both in emphysema and chronic obstructive bronchitis. But largely in bronchitis, what we're discussing, you can see thickening of the wall as opposed to the one on the left. The mucosa is also even thicker. We saw edema previously, and we have a chronic inflammatory cell in infiltration. So you have inflammation, thickening of the wall, edema, and hyperplasia of the smooth bundles or smooth muscles, and even fibrosis. Wherever you have chronic inflammation, you're going to have fibrosis due to damage of the tissue. So you have fibrosis, edema, inflammation, hyperplasia of the submucosal glands, and hyperplasia of the smooth muscle bundles. There you are. You have enough MCQs or short essay. What are the complications of chronic bronchitis? 1, patients may suffer from respiratory failure. 2, they frequently get respiratory tract infections, Haemophilus influenza and strep pneumoniae. Patients eventually develop pulmonary hypertension, which is called pulmonal. Typical metaplasia, dysplasia of the respiratory epithelium, and patients can eventually develop bronchogenic carcinoma. give me a short break as we come to cover emphysema. Excuse me. Okay. I'm back. We continue now. We're going to look at emphysema. Emphysema is defined best as abnormal permanent enlargement of the air spaces distal to the terminal bronchiole, accompanied by destruction of their walls. Really, you cannot have a better description. So we have enlargement of the air spaces due to destruction of their wall. The types are four main ones: centrilobular, panlobular, and remember lobule. A lobule is a terminal bronchiole together with the alveoli arising there. We have paraseptal, which is the septa separating the alveoli, and then you have irregular pattern, which you find it's haphazard. Emphysema again is associated with heavy cigarette smoking. And presents with progressive dyspnea, reduced exercise tolerance. So the patient used to run marathon, now they cannot run marathon. We have occasional wheezing, particularly when they are under dyspnea, and they lose weight. They lose weight. As opposed to chronic bronchitis, where the patients actually tend to eat more and they gain more. These patients tend to be chubby. We call them blue bloaters because they are cyanosed, they are chubby, they feel bloated, but they tend to be overweight. While in emphysema, they are not eating well. There are signs of hyperinflation. We'll see a barrel chest. They are pink. Actually, they're not cyanosed, they are pink. And they tend to breathe through pursed or partially closed lips because they want to protect the alveoli from collapsing. So they retain some positive pressure within the lung. Basically, we have loss of elastic support or recoil. So airways collapse on expiration, obstructive pattern is noted when you do spirometry. The patients develop respiratory acidosis. Rarely, they may develop col pulmonale, and they may also have spontaneous pneumothorax, particularly if the emphysematous region is paraseptal or around the septum. What is the pathogenesis of emphysema? One, protease antiprotease hypothesis. In patients who have homozygous alpha-1 antitrypsin deficiency, is associated with panlobular emphysema, especially in smokers. Emphysema results from the destructive effect of high protease or elastase activity in patients with low antiprotease activity. So you have the enzyme missing, that is the antiprotease missing, and the patients tend to have increased protease or elastase activity. Smoking stimulates release of elastase from neutrophils. That's why the disease is commoner in smokers. So the patients do not have enough antiprotease, then you have protease or elastase released, which in excess is going to digest the alveolar wall, leading to destruction. So cigarette smoking, particles picked by macrophages. Macrophages will activate the neutrophils. The neutrophils release the proteases. The patient does not have protease inhibitors. Eventually you have destruction of the alveolar wall or digestion. What is a gross morphology? You have panlobular, which is a respiratory bronchial, terminal alveolar units destroyed. It's commoner in the lower than in the upper lobes of the lung. It's common in the lower lobes. You have centrilobular. These are around the area of the respiratory bronchioles. The terminal alveoli are more spared. And this one now is not common in the lower, but it's more common in the upper lobes. You have paraseptal, which is the farthest of the distal acinas. These are the patients who tend to get what? Pneumothorax, spontaneous pneumothorax, due to opening or rupturing of the alveolar wall outside into the pleural space. They are commoner again in the upper, not the lower. Then you have irregular pattern associated with scarring. These are patients who have had previous inflammation or disease like TB. Histology, what do we see? We see destruction of the septal walls, fusion of adjacent alveoli. So you have many sacs all fusing together. They lose the intervening wall. The honeycomb pattern is disrupted. There's formation of blebs. blebs and bullae. Yeah, you have formation of bullae. When you see it, you see blebs and bullae. There's compressed blood vessels because of the pushing laterally, and the patients may have inflammation of the bronchioles. So there we go. We have the PATHOLOGY, which is more distal. We have centrilobular, which is the distal is preserved and around the respiratory bronchiole is affected. You do have paraseptal, which is terminal. And then you have the irregular pattern. You can't predict which area will be affected. Grossly, what do you see in emphysema? These are the blebs. These are the blebs. These are the bullae. We can call them actually bullae. Bullae in skin, they would look like blisters, but these are filled with air. When you cut the section, you're going to see the large spaces and small tiny spaces where there is air within the lung. These are the more bullae formation that we are able to see. Microscopy, these are blood vessel, that will be a blood vessel. And what you see here is destruction of the honeycomb pattern, and eventually you have large air-filled spaces. All right. We are moving fast, so that was emphysema, which is basically digestion or destruction of the alveolar wall and terminal bronchiole. We have associated clinical manifestations that we have highlighted. These are the pink puffers. Patients appear wasted, barrel chest. They've been having difficulty in breathing. The walls tend to collapse when they breathe out, so they maintain a pursed lip breathing pattern so that they retain elastic recoil and also prevent the alveoli from breathing, alveoli from collapsing. The types we've seen, there is paraseptal, PATHOLOGY, we have panlobular, we have the lobular and irregular patterns. And you've seen microscopy, what you're able to see. In microscopy, you see the destruction of the walls, the loss of the normal honeycomb pattern. And at gross, you see the bullae, irregular surface, bullae formation, and the lungs tend to be lighter than normal. So bronchiectasis, a chronic necrotizing infection. Necrotizing means there is a loss of tissue through necrosis. And this of the bronchi and bronchioles associated with abnormal permanent dilatation of the airway. So we have focal disease, there's destruction and dilatation of the airway, which is permanent. And then there's necrosis, there's death of the tissue. It presents with a cough, productive of large amounts of foul-smelling, purulent sputum, hemoptysis, and digital clubbing. Pooled secretions in lower lobes, that is the respiratory tract, may lead to respiratory tract infections. So there's dilatation, accumulation of debris and sputum. The patients have persistent cough with large volumes of copious, foul-smelling sputum. Occasionally may have bleeding, hemoptysis. Then they have systemic effects. One is digital or finger clubbing. And the pool secretions in the lower lobes can lead to respiratory infections. So we've said clinically, we're going to describe it as a chronic dilatation of the bronchi marked by fetid breath and paroxysmal coughing with the expectoration of mucopurulent matter. So we see the airway. You have local destruction, so part of the airway becomes dilated or widening. Focal disease. When it dilates, there is extra mucus which collects in the widened abnormal airway, and this is prone to become infected. So you have mucus that are not being cleared from the airway, and they eventually lead to, there's infection that accumulates within the pool. This can occur involving one or two bronchi. However, sometimes many bronchi are affected. This is a normal lung with the normal bronchial distribution pattern. And this in bronchiectasis where you have blockage here, and subsequent dilatation of some of the terminal airways. Morphological types. We may have the cylindrical or the tubular bronchiectasis, which remains in tube pattern. You can have the one that has varicosity type, and you can have the circular or cystic bronchiectasis. So cylindrical, varicose, and cystic. What's the etiology of bronchiectasis? One, bronchial obstruction. Due to what? Tumor, foreign body, swollen, swallowed coins by children or beads or foreign material. Mucus impaction, like in asthma, where you have mucus impaction due to bronchospasm and associated inflammation, and chronic bronchitis. You can have particular infections that predispose, like TB, Staphylococcus aureus, ABPS, sorry, ABPS. We have measles and pertussis. Congenital conditions that lead to bronchiectasis. Number one, we have congenital bronchiectasis, where the baby can be born with already a dilated part of the bronchial system. Patients with cystic fibrosis, these patients lack alpha-1 antitrypsin. They also lack the activity of the cilia. They have cilia. They tend to produce very limited amounts of mucus, which is usually very copious, so not easy also to brush out. You can have intralobar sequestration, immunodeficiency, Cartagena syndrome, and yellow nail syndrome. So in cystic fibrosis, you have the cystic fibrosis, the R protein product from the gene, the human chromosome number 7, the long arm, and you have the model of protein in the cell membrane. Basically, what is altered is, number one, what is allowed to get out of the cell. Number two, you have effect on the mobility of the cilia. So in the pathogenesis, the pathology comes up as a result of bronchial obstruction, where you have atelectasis. You have dilatation of the walls of the patterned airways. Now, when you get infection, you have bronchial wall inflammation. The walls become weak and dilate further because they're more pliable. Then in cystic fibrosis, you have squamous metaplasia with impaired mucociliary action. You also have frequency of infection, necrosis of the bronchial and bronchiolar walls. In cartilaginous syndrome, you have absent denain arms in cilia, so there's loss of ciliary action. Gross, what do we see? Gross morphology usually affects both lower lobes, maybe localized. You have dilated airways, which could be cylindroid, fusiform, or circular. You have cystic pattern of cut surface of the lung. Histology, you see mixed active and chronic inflammation. There's disformation of the epithelium, as you've seen, particularly in cystic fibrosis. There's necrotizing ulceration in that particular local area that is dilated. And also we do have squamous metaplasia. This can be a pre-malignant condition. You have necrosis and lung abscess formation, and eventually you also get fibrosis. There are vicious loops that do exist, particularly with smoking. Hello? Hello? Yes? Yes. This one. Sorry, apologies. Where do we start? We can start at infection, pertussis, inflammation of the wall, bronchiectasis, bronchial obstruction, infection, vicious loop. Wherever you begin, you're going to have inflammation, damage to the wall, dilatation, obstruction due to destruction, and filling up with necrotic debris. Clinical manifestations of bronchiectasis. The patients present with persistent or recurrent cough, which is productive of purulent amounts of sputum. Particularly in the morning, the patients have a very bad smell, halitosis, they cough, and they produce copious amounts of sputum. They also have bleeding, hemoptysis. The initiating episode may be notable. The patient may have had severe pneumonia or insidious onset symptoms, or asymptomatic. Sometimes they may have had an unproductive cough. Dry bronchiectasis occurs in the upper lobe because the upper lobe is easier to clear the sputum. Patients will also present with dyspnea, wheezing, and widespread bronchiectasis or underlying COPD. Exacerbation of infection. The patients now will have sputum volume, which increases, which is more pus-like and bloody. The patients may have other systemic manifestations like fever in the process. These are CT, and we should be seeing areas of like this particular area, which has ground glass change. And here we cannot see this bronchial. Usually you want to track bronchioles because you see the dark, the pitch black is air in CT. The obstruction is around here because you can see accumulation of water and inflammation about this zone. And the area, and on this other lung, there's widespread disease. So in the right, you have widespread disease. On the left, we have this area affected. So the obstruction is up somewhere. You have consolidation here. This looks like consolidation or inflammation around this pale area. The bronchioles are very thick-walled, which means there's inflammation in that particular zone. This is a bronchiole filled with inflammatory debris. So this is the material that is coughed up. Then you have diffuse inflammation and also a bit of destruction of the surrounding bronchioles. The wall is irregular with destruction of the underlying epithelium. Diagnosis, of course, is through lung function. There's a sweat test. Increased sodium and chloride is found in cystic fibrosis. You have bronchoscopy where you are able to identify where the obstruction is. Maybe there's a foreign body or a tumor, which can be taken a biopsy or removed. You can check immunoglobulin levels. The function and presence and function and structure of the cilia can be assessed in cartilaginous syndrome. Complications, one is recurrent infections. Patients tend to have recurrent pneumonia, lung abscess, destruction, sustained inflammation leads to an increase in neutrophils. Recurrent infection may lead to septicemia. You have called pulmonale. Metastatic cerebral abscess, yes, you can have an abscess due to a dislodged bronchial sputum collection, and you can have chronic amyloidosis due to secondary amyloidosis due to the persistent inflammation. Good, I think we are finished in record time now. Yes, for bronchiectasis. So we have asthma. We are going to brush over it. We say this is not a classic distinctive chronic obstructive disease. It's actually a restrictive disease, which is caused by hyperreactive bronchioles, leading to episodic reversible bronchoconstriction. So this is episodic. When there's a trigger, there's a reversible bronchoconstriction. We have bronchospasm, which presents as a cough and dyspnea and a wheeze. We have status asthmaticus, which may be fatal. This is the moment where you have unremitting bronchospasm that is persistent for a long time. Patients who have allergic phenomena, exposure to occupational reagents. We have type 1 reaction, which is extrinsic, and type 2 reaction, which is intrinsic. So type 1 is where there are patients who react to externals, smoke, and these are IgE mediated, where there's exposure first and then development of the mast cells, which need to link with IgE. So these patients have elevated IgE levels. We have the intrinsic level, which is triggered by respiratory infections, aspirin, and exercise, the intrinsic part, which you may not find. We have more actually features. Atopic or type 1, you have exposure to photosensitized or presensitized IgE, coated mast cells, to antigen, which causes acute immediate response after degranulation, release of histamine and other pro-inflammatory chemokines. We have chemical mediators like histamine, cytokines, platelet activating factor, and glucotrienes. and there's also a late phase. Then an atopic, which is virus-induced inflammation of the respiratory mucosa, which lowers the threshold of vagal receptors to irritants. Aspirin-sensitive asthma, also associated with rhinitis and nasal polyps. And also we have occupational asthma. These are the non-atopic types. We see type 1 hypersensitivity, we know what happens. Antigen. Usually we should start here, where you have T helper cells, they present the antigen, release interleukin-2, activated B cells, then you have the mast cell already with high molecular weight, IgE attached to it. There's release, activation also of the eosinophil to release histamine, proteases, cytokines, and all those major basic protein. Airway hyperresponsiveness. You have mucus production, goblet hyperplasia, mucus overproduction, mucosal edema. Eventually you have smooth muscle hyperplasia. Interleukin-4R alpha is also triggered through directly from T helper type 2 in the type 4 hypersensitivity pattern. So it has those two pathways, type 1 and type 2, type 4 induced asthma. Here we have the house dust mite as a known cause of asthma or a trigger for allergic reaction. Bronchial asthma morphology. Grossly, you have hyper or over-distended lungs. So if you take an X-ray, you see the chest is full. The ribs are stretched by the hyperinflated because there is closure of the bronchiole with air within the bronchiole, within the terminal zones. So the lungs are full. You have mucus plugs occlude the bronchioles. So there's inflammation and also hypersecretion of the mucus. There's thickening of the basement membrane, edema, inflammatory infiltrate, numerous amounts of eosinophils due to the allergic phenomena. There's hyperplasia of the submucosal glands and also bronchial wall muscle hypertrophy. We have Kochman's spirals, which are mucus plugs. And we have also Charcot-Leyden crystals, which are eosinophilic material arising or crystals arising from eosinophil membrane protein. Histology. So here we have thickening of the basement membrane. This pink zone, this pink line is thickened basement membrane. You have edema in the submucosa, and you have hyperplasia of the mucus glands and patchy inflammation. Complications. The worst is status asthmaticus, where you have a permanent attack that leads to death usually if the patient is not easily intubated and given oxygen and medication to release the spasm. You can have pneumothorax due to the tension within the chest, within the lung. We can have pneumothorax with due to effect in the lung into the pleura, allowing the air to flow into the pleura. Bronchiectasis due to the inflammation and edema and injury to the bronchiole, and eventually cor pulmonale, which is a disease of the right heart due to increased resistance through the bronchial system. You have increased resistance in the bronchial system, so you have backflow of pressure into the right heart. So the patients develop hypertension, pulmonary hypertension. Thank you very much. We've been able to understand key things on bronchial asthma. We have looked at bronchiectasis, emphysema, and bronchitis. These are the famous obstructive airway diseases. They are correlated. A patient may have more than one disease. You've seen already. You can have a patient who has asthma and bronchiectasis. You can have a patient who has emphysema and bronchiectasis. So they are quite interlinked. It's an interesting chapter, not very complicated and complex. It's something that you can read, revise, and understand properly after this. And thank you for your patience and for your understanding. I hope you've taken home everything. We can pick some questions. Okay, someone says they do not understand the definition of, and this is Bashir, chronic bronchitis. Chronic bronchitis is a patient who presents with persistent cough, which lasts for about 3 months, and it should be recorded in at least 2 consecutive years. So 2020, the patient developed a cough. The patient was having a productive cough from the month of January, February, and March 2020. They were treated, they recovered. 2021, the patient starts coughing again, and they cough up to 3 months again, productive cough, and it lasts for at least another 3 years. So you need at least 2 years of cough to be diagnosed to have chronic bronchitis. The other thing is that there are the other characteristics. The patients tend to be chubby or obese. They tend to suffer from cyanosis because they are blue. We call them blue bloaters. They get recurrent chest infections, just as majority of the other patients with obstructive airway disease. Okay, I hope you understand. 3-month cough for 2 consecutive years, plus the other manifestations. And Juki Karanja, repeat on the complications. I guess complications of chronic bronchitis. Okay, generally we have the complications. They tend to be very interrelated because pneumothorax is common in asthma and is also common. It's also very common in asthma and emphysema. Those patients tend to have pneumothorax due to rupture of the alveoli into in the pleural space. Call pulmonale is commonest in asthma. You can also have it in chronic bronchitis. You find wheezing in both asthma and wheezing in chronic bronchitis. So the clinical features have to be picked well. There's a risk of pneumonia or further infection because of the accumulation of foci of inflammation due to bronchiectasis and also chronic bronchitis. The patients tend to have infection, frequent chest infections. Okay, someone wants to see the ground glass morphology. Now, look at this area. It's the same area that we're going to see the ground glass. This area is lighter, it's more browner than darker. Normal lung after death usually has hemosiderin, so it has some hemosiderin and fibrin due to leakage from the vessel. Here you have consolidation. Here we have consolidation. You have some of the bronchioles that appear very blocked. Like this one has very little lumen. Even this one, even this one. This is what will appear ground glass on CT. This segment particularly, this segment has a more hazy, it has a more hazy pattern. And this is what we have been seeing in a lot of COVID cases. It just means there is distal or proximal obstruction. You have accumulation of fluid. This lung is not draining through the bronchial well. So there's accumulation of fluid within the spaces, the air spaces. The other thing we should be able to see is dilatation of the bronchiole, which you are able to see here. All right, gentlemen, I wish you a lovely evening. I know you have another class. I'll release you to go prepare and make sure you master the topics. The best thing is always, as I say, polish the work for the day as you finish the day so that by weekend, at least you can have a day to relax and recuperate and have a great week ahead. Bye-bye.
Bye-bye, Dr. Zuriel. Thank you for your time and advice.
Welcome. Bye. Bye-bye.